So this is an 81-year-old lady who presented a few days ago with a non-STEMI. She has several comorbidities. Importantly, she has lung neoplasm, and she is taking immune therapy for this. She's a lady who's been treated for dyslipidemia and hypertension, and she's morbidly obese with a weight of 116 kilos and a BMI of 52. And she's had a pulmonary embolism in the past, for which she's anticoagulated with a DOAC. And on top of that, she suffers from chronic arthritis. Next slide, please. So these are the shots of the left system. So you can see a very tortuous, very heavily calcified LAD with a severe tight lesion in the mid-vessel. There's further disease downstream, and there's disease involving the diagonals as well. The circumflex is equally heavily calcified and tortuous with a tight stenosis mid-vessel. Next, please. The left main is relatively free of disease, but it has calcified plaque as well, but no flow-limiting stenosis. Next. And this is the right, so it's a codominant system with, again, heavy calcification throughout that vessel with a tight lesion mid-vessel with a calcified nodule in that mid-vessel. She had an echo which showed preserved left ventricular function, and there was no significant valve disease.
So we're going to have to move on. I don't know what the problem is with the rotablator, but let's get the microcatheter, get the workhorse down. Let's get a 1.5 balloon. Let's give some neo because we're having some hypotension.
Avoir 3 de néo, s'il vous plaît. Ouais. Et puis un 1.5 ballon, s'il te plaît. Merci.
So, you know, this is the typical of, not typical, but it happens with live cases that you run into problems and you have to be ready to deal with it. Let's go.
Yeah.
No, pull the wire.
Yeah.
Feed me the micro. Okay, fixed point. I need a fixed point. Give me the run through now. Prepare the run through.
Yep.
Fixed point, fixed point. Fixed point. So I'm delivering my microcatheter. We're going to have to try to open it up with a balloon because we have having issues with the rotablator. Okay.
Ouais. On va reprendre le run-through.
Run-through. Can we take out the guide liner? So it's very important that you have a backup plan.
Prends un guide liner, s'il te plaît. Tu as le rota? On va prendre le ballon.
So my focus now is to get the artery open because maybe I was in it too long. Give me the inflator.
Yeah.
Okay, we're taking out the microcatheter,
Okay.
go up. Okay, let's take the 1.5 balloon.
Yep.
So the pressure is back up.
Yeah.
What was the ACT?
Super.
Okay, so I think we crossed the first lesion with the 1.5 balloon. Of course, this is not ideal for plaque modification, but if you can cross with a balloon, that means maybe I can get an IVL down. Let's go on. Let's go to 12, not burst the balloon.
Yeah.
Off. Okay, let's get a 2.5 balloon, please. Okay, go on.
12.
12, 14,
14.
off.
Yeah.
Go on again. So the balloon seems to be opening up, which is promising.
14.
Off. Okay, you can release the balloon. So this is a poor man's IVUS. To know if the lesion is crossable is to cross a used balloon. So the 1.5 went through. Which means probably I'm going to be able to get a 2.5 in.
We'll take the 2.5.
So let's check the flow. Okay, so restored flow. It explains why the pressure came up easily. So I'm guessing that lesion was subtotal. I was in with the rota wire. There was issues with the rota device, and it led to decreased flow somehow. Having the wire in sitting for a few minutes. So 2.5 balloon went in. Let's test. Yeah. That's good. All right, let's go on here.
Mm-hmm. Use.
Off. Go.
Use.
Off. Okay, so we'll perform IVUS then.
Yeah.
And then at least get an idea of what we're dealing with. So yeah, like I was saying, you can have a plan and you always need to be ready to move on to the next plan if things don't go as you planned. So we use the high definition IVUS here, which is very useful in defining the amount of calcium, because when you're looking at calcium in these cases, you want to evaluate the depth, the length, and the arc of calcium to determine the modality. So I got the balloon open, 2.5 balloon. I want to know now, do I need to do further modifications with IVL, or can I go ahead and stent and the chances of having good result are still high? All right, so my IVUS is through to where I want it. Let's get the IVUS going. Now the image is on. Can we see the IVUS? Okay, perfect. Okay, need to make sure it's well flushed. And we'll start the pullback. So there's a lot of shadowing going on. We should probably see the dia coming in shortly. So actually, Jimina, if we look at this and everyone, we don't see much calcium in the distal. So now we're getting at that curve where we see the branch. There's the dia coming in. And there's an arc of calcium. It's about 180 degrees. It's more than 0.5. Now there's less.
Yep.
We're going to get to that point which is heavily calcified. We have an arc of 180. There's diffuse plaque, nodule now. Mm-hmm. You see behind it, there's a lot of shadowing.
Yep.
It's pretty thick calcium. Yeah. So here it's 360.
Yeah. Some fractures from the balloon.
Yeah, we see the fracture from the balloon, correct. It's pretty thick. Here's diffusely infiltrated. I'm in the proximal segment. Now it's okay. So we have a good landing zone and probably going to need to measure to size the stent. Now in the proxial AD. Circumflex coming in. Oh, it's still in the proxial AD. It was the first D1. That was D1.
Yep.
All right. So now in the left main soon. So there's a lot of calcium, but it doesn't seem to be 360 in the left main or the proxial AD. All right. Can we get a reference diameter on the proxial AD?
IVUS revient.
On va prendre la mesure dans l'IVA proximal juste avant. So I think it's not that terrible. I don't think it's worth IVL in this case. It's 180 degrees. It is thick, but we have caused cracks with a regular balloon.
Yeah.
Can we have a measurement here? I think what I would probably do is a non-compliant 3.0 balloon.
Yeah.
And this is that's the measurement we have in the proxy LED. Yeah, 3.0 balloon.
Here,
I think a non-compliant is sufficient since we already caused cracks. I just want to make sure we have good expansion. So let's get a 3.012 non-compliant balloon, please.
Okay.
So the question begs itself here. I ran into issues with my device and I did not go as I planned, but backing up, like, was the rotor necessary from the beginning? I don't think there was a way to determine that from the get-go, since it looked on Anju heavily calcified, and the lesion was subtotal. Yeah. So there would have been no way for me to evaluate this imaging. But I think this is an interesting demonstration that shows, okay, I ran into issues, I used my backup plan, and now am I going to be in trouble afterwards, after stenting? Is there going to be under expansion? So I think we answered these questions with the IVUS. Yeah, 3.012 non-compliant.
It's on the way.
So I think getting into stenting here, I'm going to use two different sizes of stents for the distal landing zone, as we know that in the LAD after each bifurcation, the size goes down. So I've measured 3.0 in the proximal. Post-diag, we have 2.5. So we'll start with a 2.5 stent for the distal, and then we'll put a 3.0 in the proximal segment. Can I have a 2.5/18 stent, please? I have a guide liner ready just in case. Test?
Yeah.
Okay, let's go here.
12.
14.
14.
Okay, that looks pretty good.
It's gone up nicely.
Off.
Off.
So every time we go up with the balloon, we get drop in pressure. Let's go here.
14.
Off.
Off.
Let's go here. 12, off. Check there. Yeah, very good. Go. Off.
Not much wasting.
No. Size looks pretty good. Go on. Off. Okay. I think it's pretty satisfying. We have our tech people verifying the rotablator, seeing what's going on, if it's a valve issue or what, because the case is not done yet. We still need the to manage the circumflex.
Do you want a 3.5?
Okay, let's get the 2.5 by 18 stent. So we'll see how the stent delivers. I'm suspecting it's going to go well since the balloon, there was no waste. And my plan is to put a 2.5/18. There you go. Nice. That was good. Let's test that.
Yeah.
I'm covering the bifurcation. It's a small vessel. Go. It's short in terms of short. Go on. Let's go to 12, nominal. Yeah. And I'll take a 3.0 stent proximally. Looks like it's a 23. Off. So I inflated the stent at 12. And then I'm going to come back to the bifurcation, do like a pot, and go to higher atmosphere. Check there. Okay, let's go there. Go to 18 here. So this is like a pot at the level of the D2. All right, off. Okay, let's check where we are. Okay, I think this is good. If we take a 23, we'll be fine.
Agree.
Let's take a 3.023 stent. Perfect. So she's very liable to inflation in the LAD. Every time we go up, we get drops in pressure, but they come back up right away. I think here the change in
3.5.
3.0. Yeah. I think the rapid change in strategy here was quick. Once I saw things changing and the rotoblader not coming along, it was the right decision. Okay, let's do a dry cine to see where we are. I think we are missing a little bit for the stent. Okay, that should be good. Test, are we covering everything? I think we're missing a bit.
Tiny bit.
Yeah, so we'll take a 28, 3028. I prefer changing stents than adding another stent and having a different overlap. So we'll take a 3028 stent instead.
So
do we know if the rotoblader is working? So maybe the issue is the motor here.
Yeah, possible.
It's very unusual to have such issues with rotoblader. Actually, this is the first time it's ever happened to me. I do at least 3 rotobladers per week and never ran into such issues. Oh. Okay, much better length. We'll do another dry run. Make sure I'm in. Okay, I'm in. Let's go on.
Good. On. Good.
14.
14.
16. Well, maybe we have some under expansion in the proximal segment.
Possibly.
18 off. So I'm suspecting some under expansion in the proximal segment. We'll recheck it with IVUS.
Yeah.
If there is under expansion, then that means I need IVL. It's very unusual because when we saw on the IVUS prior, there was no high risk features that this would happen. Well, it doesn't look bad.
Yeah.
Well, we didn't get that proximal segment, I think. Distal landing zone. There's maybe spasm. Let's give some nitro and see what's going on. Pressure is lowish.
Nitro.
Hold on, pressure's a bit low. Let's give some neo. Let's give 4. Very sensitive to the LAD. Whenever I go work in the LAD, there's stuff going on. You know, sometimes the type of patients this is usually a sign that you need to respect when you have small forms of hemodynamic instability with calcified coronaries like this. Usually it's better to make things short and sweet, not to stay along too much, because she showed me that she's sensitive. I think I'm going to add a distal stent. Let's take a 2.012 stent, 2.0 by 12.
2.012 stent.
So it looks like there's some questions. Any role in drug-eluting balloons in this situation? I don't know if you're referring to the distal edge of the stent, but possibly. But we have the 2.0 balloon, 2.0 stents, so I think that's a good option. Laser, I don't think there's a role for laser in cases where we manage calcium, because it doesn't really debulk. It's good for uncrossable lesions, so you can cross. But for debulking, when you have calcium, I don't think laser is very useful.
Yeah.
So I'm just going to put one final stent distally because there's a pinch. I don't have much room for nitro, and we need to have a good runoff for the work. And you know, I've had several cases like this with tortuosities and calcium, and you know, when they go hypotensive frequently with the balloons, it's usually really a sign. Maybe if we had done rota, we'd have had more no reflow, and it would have been an issue.
And the ACT, Rachel? Probably. Okay, thank you.
In my experience, this stent usually tracks well, the 2.0. It's not advisable, but I don't want to run into distal issues and having to. Oh.
Yeah, it's
there you go.
Through the two layers.
I don't know if you caught that, but that was pretty nice tracking with a little bit of push. Let's check that. Check. Okay, there you go. Okay, let's go here gently. Let's go to 10. Just barely deploy it, and then we'll optimize it after. All right, off. Go. I think for the drug-eluting balloon in the distal segment, probably I would have run out of drug by the time my balloon gets down there because of all the friction that's going on upstairs. So it probably would have been a good option had this disease been there initially, and I was, stuck in dealing with it at the beginning. But if you use often drug-coated balloons, if you wet them going in and you observe, there's no more drug on it. So let's do some IVUS here. I want to evaluate that Proxel AD. There's some plaque. The stent looks good. I just want to be sure before I get out of there and get into the circumflex that it's okay to leave the LAD now. Okay, let's properly flush the IVUS before going in. And let's advance it. Flush, yep, flush, flush, flush. Very well. Hold the wire. All right, let's follow me with the device. All right, so I'm not going to try to push things down. It stops here. Let's see how things look like. Okay, we're live with the IVUS. Let's start the pullback. Perfect. So the stent here is well expanded. We still see the calcium behind. It's well opposed. Everything is round. I'm pretty happy with that. We'll get into that proximal segment soon where we see what I suspect is some under deployment. It still looks pretty good. Looks very well. The plaque is opposed. Stent is well opposed.
It's quite nice.
Honestly, I'm pretty happy with this. We're getting into that unstented segment. There we go. Oh, so not yet. Still some stent. Still stent. Should be getting into it anytime soon. Well, there you go. So there's plaque, but it looks fine.
Yeah.
It looks fine. We'll take a measurement on this area. It looks pretty good. Honestly, I'm happy to this point. All right, we're in the left main.
Nice.
So can we just get a measurement on the Proxel AD? And we'll, I think we'll start wiring the circumflex now. So plan for the circumflex. I don't have my rotablator back. Looks like this is going to be old-fashioned. All right, let's get the run through.
Yeah. Thank you.
So let's take a look at the. Do you have the measurement on the IVUS? You'll need to expand the yellow a bit. The inner diameter measurement to the right side. To the right. That's the left, the right side. Yeah, expand more. Yeah, so we have 2.5 by 3.5, 3 by 3.5. I think this is sufficient lumen. 7.4 of MLA in the Proxel AD. Despite that it looks that there's plaque, I think IVUS here is very useful in demonstrating that we can leave this alone. This wire is not good.
We'll take a new run through, please.
So is it possible to have my slides? I had demonstrated in my slides some interesting points comparing different. We need a run through and the slides.
I'll run through.
Yeah, so if you take a look, I was comparing the three different modalities and when it's most useful for each. So IVL is very useful when you're dealing with bifurcations and you need to have your two wires in place. And when you're using IVL, you have much less of a downstream of no reflow and debris. So when you're dealing with a fragile patient, like in this case, for example, you have less no reflow and less of hemodynamic instability, which could be very useful. It's easy to use and it's safe, but it's very costly. But in the scheme of things, it's not more expensive than orbital atherectomy, for example. Okay, let's go to spider, please. Next slide. And this looks pretty small, but it's comparing comparing when to use rota versus orbital.
So rotablation's been around for a while. There's different. Both are easy to set up, relatively easy for the staff to set up. There's different sizes of burr for the rotablation, and accordingly you need to plan your sheath size as well to factor that in. The main advantage of rota is it's good for uncrossable lesions. It deals quite well with tortuous, very calcific, stenosed lesions. The orbital atherectomy comes in one size of crown, and it can deal with vessels from 2.5 to 4 millimeters. It deals less well with tortuous vessels, and you need to be mindful of the possibility of perforation if you're trying to use orbital atherectomy for very tortuous calcified lesions. But it is very good for deep-walled calcium. It has got bidirectional movement to it, so it's sharing both ways. And there is less of a risk of wire bias, as you can sometimes appreciate more with the rotational atherectomy. I don't know if you've got more to add.
Those are the very good points.
Yeah.
Can we get a 2.5 by 15 balloon, please, non-compliant? So I think the point of attaining deep calcium is very important when you are comparing both devices, because the rotablator stays central. If you want to get that deep calcium, you need to upsize in burr. But if you upsize in burr, you run the risk of having no reflow, which is more if you don't stay within that ratio. So far, I crossed with the run through. I don't have the rotablator back. I can either go with IVL or take a go at it with an uncompliant balloon. And I think I saw a proximal curve. I'm just going to go at it with an uncompliant balloon and then do imaging to help me decide if I need otherwise. Next slide. So the disadvantages of each device. The rotablator, like I said, stays central in the vessel. There's no retrograde atherectomy going on. Go up to 12. The balloon went through very well. So no retrograde means if you're dealing with a severe lesion and you get stuck, you're stuck off. You have to manage burr stall. Go up. So the balloon went pretty good.
Yeah.
We don't have any wastes on it, surprisingly. Might be our lucky day off. Okay. So let's do a run of IVUS then.
Although I have to say, I was quite keen for you to show us your one-man technique for the rotablation.
It's going to be for another episode,
which
I guess.
as a fellow has been quite useful to see. Okay, so IVUS time?
Yeah. Next slide. So we'll show the conclusion later on.
Yeah.
So maybe if I didn't manage to do rota like we planned, I think the learning point from all this is that the IVUS findings correlate with the procedure that we had to deal with. We did not see concentric 360 calcium on the LAD on the IVUS, but we suspected that strongly on the angio, which here comes to show you the limitations of angio. But I could not have done IVUS here prior because it was a subtotal lesion. So yeah, okay. I guess we learned it the other way around. All right, yeah. So ready for the IVUS in the circumflex. We have good images. Start the pullback. So again, it's very similar to what we find on the LAD. We can see short runs of calcium. It's 180 with thick calcium. It is thick though. Yeah. And it lungs all throughout the vessel. So we're getting to the mid-circ. Thick calcium, but it's patchy, small nodules. Yeah. So the vessel looks like it's a 3-0. There's an incomplete arc. Yep. Maybe a nodule. There's the branch coming in. Remember, on the angio, it was a very localized lesion. So that's also in favor of trying to go at it with a balloon. We probably already fractured it with the 2.5. There's diffuse infiltration proximally, but I measure 1, 2, 3. 3 one side and 2.5 on the other side. Yeah. Well, that's the proximal segment, so it's 2 by 2.5. Yeah. Well, maybe we'll need to cover that. Yeah. We'll get an MLA on it. Yep. Okay, maybe we'll just cover that whole mid segment. Well, it really is at the proximal segment. There's stuff going on. You see that LAD wire now. All right, stop. That's out. Okay. So can you measure? You see it's very diffusely infiltrated on the longitudinal view. Tu peux nous mesurer où c'est le plus serré aussi? There, okay. S'il te plaît. There. Où c'est le plus serré si tu fais un area. Ouais, le plus petit. Yeah, there. Là. So that's a very thick calcium area, but it's not 180. So we have 4.3 still, so it's not that bad. But okay, I'll tend to cover probably the whole circ till the mid segment. Let's get the 3.0 non-compliant balloon that we had. Yeah. Make sure we have expansion on that, and if we run into issues, we'll get out the IVL. Yep. I think with confidence, we can really rely on the imaging findings in determining calcium modification techniques, which has been demonstrated so far. Now, you know, had the 1.5 balloon not crossed in the LAD, what would have been the option? I think I would have been inclined to take out the orbital, but had to keep in mind the hemodynamic instability that we had a few times. All right, let's go to 12 here. Yeah, we'll see how that expands. Very well, off. Yeah. Do a test so we can see the length that we need. So it stopped a bit before. That's a 15 balloon. We'll need 33 probably. Yeah. On. Okay, off. Gone up really nicely. Yeah. So let's go to the spider view. Let's see where we need to stop proximally. Can we go search for a 3033 stent, please? Okay, we can stop there. That's fine. A bit of caudal. Centralize. Okay, let's do a test. Okay, let's get this area. Okay, go there. That will be my landing zone. Yeah. Oh, it's sliding. Oh, it's open though. Yeah. Off. Test. Okay, go there. Yeah. 18.
Yeah.
Okay, it's well open, off. So let's see if the 33 goes through directly, or I'm going to need to use a guide liner. Honestly, it's better this way to prepare for the worst and not need it than to the other way around.
Yeah,
you know,
agreed.
Let's test here, place it proximally and then change views. So it went through pretty nice. I think we have a little bit left there. Just test again.
Yeah.
Okay, test there.
Not bad.
Yeah. There. You want to flush. I just don't want to get in the main and run into issues. So maybe you'll go there, test. That's a bit in the main.
It is, yeah.
Okay, a little bit, very millimetric placement here. Distally, I'm not worried. I'll just go in, place a distal stent if I need, test there.
There.
Yeah, that's good. Go ahead, take it.
Yeah.
So go on to 12.
12.
So here's a good demonstration to know where you are. You do a test while inflated. I think we're in.
I think so.
Maybe there's a millimeter into the vessel. Can you save that off, please?
Off.
Go in 15. We'll check if we got the distal segment.
Yeah.
Do a test here. That looks pretty good. We might have lost a small branch,
yeah,
but I'm not going to sweat it.
We need to post dilate a little bit the proximal segment.
Let's take a 3.5 by 8 non-compliant balloon. So do a cine here to see what's going on. Honestly, looks pretty good. Yeah. Other than that dent, we're gonna, I think, get it with a 3.5 balloon. We can do IVUS. But so far, I'm pretty happy with the results.
Interesting
honestly.
That we got it without the rotor. Yeah.
So if we can show the conclusion slides.
Can we
Since we're almost running out of time,
yeah,
but I want to make sure to get those in.
Rachel, tu peux lui demander de nous montrer les slides, s'il te plaît?
Yeah, so in conclusion, surgical turndown patients, they pose a significant challenge for percutaneous revascularization. You need to be prepared for the multifaceted patients with their several comorbidities and dealing with them. Adequate revascularization of these patients requires proficiency in various calcium modification modalities. So an example in this case, we didn't use anything very complex. The plan was to, but had I needed something, you need to be sure that you know and are comfortable with them. Okay, we have good expansion on the 3.5 balloon. That's very good. Okay, off. And I think in these cases, they are very complex as they are, and simplifying these complex procedures, maybe breaking them down into steps or taking them one by one, will assure that you do not run into complications, because usually these patients are not very forgiving. In terms of complications, you don't have time to react. When it goes sour, it really goes sour pretty quickly. Let's give one a nitro, push it. That's pretty good. I think we can pull the wires. Yep. Let's take cine here. Pressure's good. Let's go, cine. Okay, that's pretty nice. Yeah. Okay, let's go to cranial view. Have one last image before we go close. Yeah, everything's good. We're good on my side.
Good.
Okay, one final image.
Yeah.
Wow, that's pretty good. Let's see distal. Excellent. I'm pretty satisfied with the results. The RCA, I think I'm going to send it back to the treating physician and ask for some nuclear evaluation, see if it's worth the trouble. But, you know, with all these comorbidities, if the patient remains asymptomatic, preserved EF, and we got away with 3 stents.
Absolutely.
I think I call this an optimal result.
Yeah.
So thank you very much, everyone, for joining us.
Thank you.
And I hope this was informative. Let's do an angio of the groin.
Yeah.